Good morning. My name is Jeff Reznick. I'm Chief of the History of Medicine Division at the National Library of Medicine. Welcome to everyone. Before I introduce two individuals who will welcome you here formally, I'd like to, and before I introduce our keynote speaker, I would like to take a moment to offer my personal welcome to all of you and my thanks to all of the individuals and organizations who have helped to bring this presentation this morning to fruition, as well as the associated workshop. The support of the National Endowment for the Humanities has been integral, and without it, this presentation would not have been possible, and the workshop simply would not have been possible. The contributions of Virginia Tech have been outstanding. Tom Ewing and his colleagues stand among the best colleagues and collaborators one could have, and representing Virginia Tech here today is Dr. Stephen McKnight, Vice President of the National Capital Region at Virginia Tech. And we thank Dr. McKnight for coming and for the support of his institution in realizing today's presentation as well as the workshop. The support of the Wellcome Library and the Wellcome Trust has been tremendously generous, and thanks especially to our colleague, Dr. Simon Chaplin, Director of Culture and Society at the Wellcome Trust, for his time and his support. My colleagues at the National Library of Medicine have made wonderful contributions to the success of today's workshop. Thanks especially to Beth Mullen, Manager of Web Development and Social Media in the History of Medicine Division, for her fine work in producing the associated series of blog posts that were published just last week on our blog circulating now. And thanks also to my colleague Ken Coyle, Deputy Chief of the History of Medicine Division, for his contributions to the success of today. This workshop represents great partnership across disciplines and great multi-institutional collaboration. Everyone who's been a part of it and putting it together should be duly proud. It's my pleasure now to introduce two individuals who will welcome you formally. Betsy Humphreys is currently Acting Director of the National Library of Medicine, appointed to the position on April 1st, 2015, following the retirement of Dr. Donna Lindberg. At the time of her appointment, she was, and she remains, NLM's Deputy Director, a position she's held since 2005, sharing responsibility with the Director for overall program management, program evaluation, policy formulation, direction, and coordination of all library activities. Margaret Plympton is Deputy Chairman of the National Endowment for the Humanities, supporting Chairman William D. Adams in his oversight of the NEH, and particularly its new initiative, The Common Good, which seeks to bring humanities into the public square and foster innovative ways to make scholarship relevant to contemporary issues. Please join me in welcoming Betsy Humphreys first to the podium.
So good morning, everyone. On behalf of the National Library of Medicine and of the National Institutes of Health as a whole, I am very pleased to welcome those who are participating in the workshop, Images and Texts in Medical History, an Introduction to Methods, Tools, and Data from the Digital Humanities, as well as everyone, whether here in the auditorium or watching remotely, who has joined us today for Dr. Jeremy Green's public keynote address. This workshop, as has been described, is one result of broader partnerships between NLM and several other institutions, and I echo Jeff's thanks. We are extremely grateful to the National Endowment for the Humanities for funding the workshop through a generous grant to Virginia Tech, and to Virginia Tech, the Wellcome Library, and the Wellcome Trust for working to bring it to fruition. NLM's role as the host of the workshop and the public lecture as part of our History of Medicine series is personally very satisfying to me for several reasons. First, I was an undergraduate history major myself, and the methods and tools of the digital humanities would have been a huge help to me in 1968 and 1969 when I was reading and attempting with not a great deal of success, I would say, to analyze the themes in literally hundreds of oversized pages of the English parliamentary debates. I think anyone trying to do this today would have a much easier time than I did. Second, throughout my career, I have been privileged to work with stellar interdisciplinary teams from NLM and elsewhere, including the Wellcome, who have greatly expanded the available universe of digital metadata, full-text scientific data, and images, and have also built novel resources that support biomedical text data and image processing and mining. It's great to see the fruits of all these labors put to good use in the history of medicine and science and in the digital humanities, as well as in basic biomedical research. Last but not least, NLM's own history is closely linked to the history of biomedical communications and to successive technological advances that have promoted and enabled medicine at a distance. So I am very much looking forward to Dr. Green's lecture. Thank you all for joining us to hear him today, and welcome again to the National Institutes of Health.
Thank you very much, Jeff and Betsy. I'm so pleased to be able to be here with you this morning in supporting and representing the National Endowment for the Humanities in its support of this workshop and Dr. Green's keynote address. As Jeff mentioned, this event responds well to the endowment's special initiative, The Common Good, which seeks to support work that fosters innovative ways to make scholarship relevant to contemporary issues. In fact, one of the questions that Chairman Adams asked when conceiving that call was, how can the humanities illuminate the enormous promise of new biomedical technologies and procedures and deepen our understanding of the complex ethical and personal questions they raise? This workshop, drawing upon the collaborations of the collections of the National Library of Medicine, the Medical Heritage Library, and the Wellcome Library, and involving humanities researchers, scientists, librarians, and archivists, speaks directly to this challenge. I would like to thank our hosts at the National Library of Medicine at the National Institutes of Health for offering their wonderful facilities to our workshop participants. This event falls under the umbrella of the Memorandum of Understanding between the NEH and the library to undertake joint programs related to the history of medicine. And we would also like to thank our international partner, the Wellcome Trust. Their crucial support has allowed participants from the United Kingdom to join us for this workshop. And finally, of course, thank you to the team from Virginia Tech, who has done the bulk of the work in organizing the event. The workshop complements other Virginia Tech efforts in biomedical history, including NEH-funded summer seminars for school teachers on the history and the impact of the 1918 Spanish flu epidemic, and on race and mental health in history and literature, both of which drew upon the staff and expertise of the National Library of Medicine. We at NEH are thrilled to partner with these organizations and institutions to bring the methodologies and critical approaches of the digital humanities to the study of this important topic. Thank you again. I'll now turn the podium back over to Jeff Reznick.
Thank you, Betsy and Margaret. It's my pleasure now to introduce our keynote speaker, Dr. Jeremy Green. Dr. Green is an associate professor of the history of medicine at the Johns Hopkins University School of Medicine, where he serves as the Elizabeth Treed and A. McGee Harvey Chair in the history of medicine. Dr. Green earned his MD and his PhD degrees from Harvard University, and he completed his residency at Brigham and Women's Hospital. Dr. Green is board certified in internal medicine and a member of the American College of Physicians. In addition to his appointment at the Institute for the History of Medicine at Hopkins, Dr. Green also practices internal medicine at the East Baltimore Medical Center, a community health center affiliated with Johns Hopkins. He has published numerous books and articles, including Generic, The Unbranding of Modern Medicine, published by Johns Hopkins in 2014, and Prescribing by Numbers, Drugs and the Definition of Disease, also published by Hopkins in 2007. Dr. Green's broader research interests focus on the history of disease, medical technology, the history of global health, and the relationship between medicine and the marketplace. His presentation today is connected with his current research project, Medicine at a Distance, which examines how changing expectations of instantaneous communication through electric, electronic, and digital media transform the nature of medical knowledge. Most histories of medical technology focus on heroic diagnostic and therapeutic interventions like X-rays and artificial hearts, which stand as visible symbols of medical modernity. Dr. Green's research is focused on recapturing how more mundane technologies of communication enabled and altered the production, the circulation, and the consumption of medical knowledge, from telegraph to text pager, telephone to telemedicine, fax machine to Facebook. Please join me in welcoming Dr. Green, who'll be speaking on the analog patient, imagining medicine at a distance in the television era.
Thanks for that kind introduction, Jeff, and thank you. It's such an honor to be here today. I get to make one small correction to the introduction, which is that I just got promoted. So I'm now a full professor and tenured. So I'm all grown up, apparently, in the eyes of my university. But it really is so wonderful to be here today. There's such an energy in this conference already. A few acknowledgments. This research is funded by the Greenwald Foundation and Bioethics, and the materials I'm drawing on today come mostly from collections here in the National Library of Medicine, especially in the History of Medicine Division, and collections at the Massachusetts General Hospital archives. For this conference today on Digital Humanities, to talk about the relationship of image and text in the history of medicine, I thought I'd begin with a few unusual images that demand some textual explaining. So projected on the screen before you is a collage of image and text. The white on black text is my own digital edition, the title of the talk, The Analog Patient, Imagining Medicine at a Distance in the television era. The black on white text was pasted using a more physical form of paste along the original photographs in a report of the teleognosis clinic of the Massachusetts General Hospital located at Logan Airport. The photographs themselves depict pictures of television screens, which themselves depicted images of the conjunctiva of a model patient at the airport clinic at two different camera settings. And the intent of this odd juxtaposition of image and text was to demonstrate the fidelity of conducting a physical examination of a patient at a distance using the television as a diagnostic medium. Now, it's hard perhaps for us to imagine the television today as a cutting-edge medical technology, but I'd like to suggest, and this is really the thrust of my talk today, that there is much in the story of medical images communicated by television in the 1960s and 70s that is of relevance to contemporary understandings of new media in medicine and health today in the 21st century. And claims for the abilities of new media to inform the way we live in our bodies in health and disease are all around us. In 2012, the World Health Organization launched its mHealth initiative to use mobile digital health technologies to combat non-communicable diseases, from diabetes to heart disease to cancer and COPD. In the United States, the cardiologist Eric Topol, whose article Your Smartphone Will See You Now is featured here, is only one of the many prophets of a new electronic revolution in which new digital media promise to liberate patients from the need to go to doctors' offices or hospitals in order to receive state-of-the-art medical care. Yet deep underneath this gloss of excitement of the digital realm, deep wells of anxiety churn, ready to burst forth at any moment. Such is the case in the past month in my hometown of Baltimore, as a local hospital system was effectively paralyzed after its servers were hacked and effectively held for Bitcoin ransom unless the company paid a fee to regain access to key patient data. Many of you will have heard of this story already. I want to suggest that the hopes and fears we now project into the digital domain have a strong analog in older analog technologies. And I hope it'll be obvious by the end of this talk that narratives of enthusiasm and anxiety find powerful correlates in older histories of new media in medicine, and what I'm calling the analog patient. So this talk is part of a broader project called Medicine at a Distance, which examines the history of electronic media in medicine, from telephone to radio to internet. And I want to suggest we could go back much further than that if we just ditched the word electronic. The challenge of diagnosing at a distance is not new to the 20th century or even the 19th. A host of historians of medieval and early modern medicine, including Michael Stolberg and Alicia Rankin, among others, have described the key role of diagnosis at a distance by letters, so this practice of epistolary medicine, in which the text of a letter was often accompanied by the image of a flask of urine, which itself was used for physical diagnosis. But with the advent of closed-circuit and cable television in the late 1950s onto the 1970s, one finds an explosion of attention to the visual elements that electronic media potentiated, and potentiated a new telemedical imaginary. Along with the new potential came new fears, as evidenced by the initial image I suggested. What if diagnoses evident to the naked eye would be missed by the TV camera? For this conference on image and text, I want to focus on the role of television in offering the promise of transmitting images of patients at a distance, and what hopes and fears doctors, researchers, patients, families, administrators, activists, and others had for this new medium. Now, the National Library of Medicine was not a bystander in this process, and I'm hoping that we can get to the NLM's specific role in more detail in the Q&A. But for today's talk, I'll focus on two episodes that I think illustrate some of these hopes and fears of new media in medicine. The first explores the role of Reba Ben-Shoder at the Nebraska Psychiatric Institute. Ben-Shoder is a pioneer in fields of television medicine and biomedical communications in the 50s and 60s, and her papers are preserved here in the History of Medicine Division at the National Library of Medicine. And she envisioned, as I'll explain shortly, how to begin working with the cool media of television in the late 1950s and make it, by the later 1960s, and this is my own clunky neologism, even cooler. The second episode focuses on Kenneth Bird's experimental field station at Logan Airport, the site that produced those televised pictures of eyeballs I showed you earlier, which operated from the late 1960s to the mid-1970s. And then I'd like to bring together some conclusions about image and text in history of medicine from the perspective of these would-be televisual visionaries. One caveat before I begin, though. For the most part, works on media, history, and medicine have focused on representations of the doctor on television and film, from Medic in the 1950s through the heroic age of Doctors Kildare, Casey, and Welby, and then a more challenging world of Doctors Quincy and the cast of Saint Elsewhere until we wind up at the early 21st century with a bunch of scrubs. But it misses, this analysis misses, another, and I think potentially more surprising history of the kinds of cultural formations around the use of television that medical researchers, bioinformatics engineers were considering as they put together these projects for telemedicine in the 50s through the 70s. And this work draws inspiration from some new developments in a conjunction of media history, history of technology, that I think is largely outside of the historiography of medicine today, but really should be brought more in communication. Following Lisa Gittleman, I'm very interested in looking at the role of media with a small m, not broadcast media, but the everyday uses of communications media in everyday life. Following Fred Turner, I'd like to emphasize the role of would-be countercultural formations in envisioning equity and liberatory potential in new communications technologies. So to begin, in early 1966, Dr. Reba Ben-Shoder found herself in the middle of an audience of luminaries at the New York Academy of Sciences for a multi-day conference on the role of new media in medicine. In early 1966, as James Lieberman noted in his introduction to the conference, quote, just as 7 out of 10 prescriptions written today are for items unknown to medicine before World War II, 7 out of 10 possibilities for communicating the knowledge behind those prescriptions were not available before 1946. Lieberman was head of the Atlanta-based Public Health Service audiovisual faculty, which he described to the audience as a new, younger sibling to the National Library of Medicine. Quote, what the library does for the printed word, Lieberman noted, the Public Health Service audiovisual facility does for the visual image. And Lieberman had assembled some 40 speakers from academia, industry, and government, including advertising executives plucked fresh off Madison Avenue, heart surgeon Michael DeBakey beamed into a giant television, and National Library of Medicine Director Margaret Cummings, and the governor of American Samoa, which had recently shifted its approach to high school education to a model that used a standardized televised curriculum with a television in each classroom on the island. And the conference followed the convention already popularized by Canadian historian of communication Harold Innes, and then amplified by his countryman Marshall McLuhan, who had by 1966 been recognized as a rock star of media studies, which took a history of different forms of media for medical communication, from the spoken word to the printed word, through the photograph, telephone, film strip, and radio. And much as in McLuhan's book, The Media Extensions of Man, the television took center stage at the 1967 conference. And in part, this is in recognition of the greater interactivity that TV offered. And here we can relate to McLuhan's classic distinction between hot and cool media. Hot media, like film and radio, were those that engaged one sense entirely and made the observer, the viewer, into a passive recipient. Cool media, McLuhan argued, like television, engaged several senses less completely and required more interaction on the part of the user. Most of the speakers at the conference focus on the value of television as a medium for education because broadcast television or videotape television required more interactivity of the end user. And this had been a project aggressively pursued with NIH funding through a Council on Medical Television beginning in 1959. But this council focused almost entirely on the use of TV for education. Reba Ben-Shoder had similarly begun her career using television and telephones in this example of one of her early projects, Professor in Absentia. And I don't want to, I'm a professor in absentia at my home institution today. Many of us play that role. But Ben-Shoder began focusing on technology and health education. But when she was hired in 1957 to join the Nebraska Psychiatric Institute's efforts to integrate services to the Norfolk Asylum far across the state, she began to think critically about new uses of television as an even more interactive medium. Specifically, Ben-Shoder became interested in using new technologies of closed-circuit TV and cable to link TVs to cameras at multiple locations and provide instantaneous visual communication. The connection that gets made between the Nebraska Psychiatric Institute in Omaha and the Norfolk Asylum in Norfolk is the brainchild also of Cecil Whitson, professor and chair of the Department of Psychiatry at the University of Nebraska and the head of the Nebraska Psychiatric Institute in Omaha. And Whitson had had positive experiences with telephone as a medium of medical communications, as a way of combating problems of rural access to psychiatry in Nebraska, and thought the addition of visual elements would further enhance the ability to teach, diagnose, and treat. With Ben-Shoder's assistance, Whitson designed a basic setup of a television linked to a camera, linked by cable to another television and camera. And this is first tested just across the street between the Nebraska Psychiatric Institute and the anatomy building, literally across the street. But it's first used for teaching, then for controlled experiments, testing the ability to conduct neurological examinations and group psychotherapy in person versus in television, to see how much fidelity, how faithful was the television medium as a space for diagnosis or treatment. And with initial proof of concept in hand, Whitson and Ben-Shoder received funding from the NIH to test the practicality of this new interactive television medium to provide expert care to the state mental asylum in Norfolk, 112 miles away. The microwave link was set up between the two facilities in 1964, and the NPI became the first large-scale test of interactive television as a communications medium for medical practice. Ben-Shoder presented at the New York Academy of Sciences in 1966 some of the early results of this project. And as she reported, the principal benefit was initially thought to be educational, keeping staff and residents engaged with the materials being generated in Omaha. And this worked pretty well. There was a link for residents rotating at Norfolk to receive better instruction from their mentors, to hold joint grand rounds, and have a calendar of telelectures, lecturers who are speaking in Omaha that could then be watched in Norfolk. But more surprising elements for Ben-Shoder came from patient care and patient services. Norfolk did not have a neurologist on staff, for example, but Dr. Dutch at the NPI in Omaha could, quote, sit down in front of his camera and monitor and get to work. Early research showed, quote, it was possible to observe a reasonably detailed neurological examination on TV, and EEGs could be read quite easily using inexpensive equipment. More unexpected yet was the response of patients. More than 40% of all patients hospitalized in Norfolk were originally from the Omaha area, and many family members were unable to visit due to distance and transportation expenses. Ben Choder opened a viewing station at the Nebraska Psychiatric Institute, 8 hours a week for family members to communicate in real time with their loved ones. And TV visits, she noted, quote, played an important role in keeping the absent member in the family. And the new media offered new capabilities for the bureaucratic management of ward life. 27 wards in the state hospital had been run by only 3 psychiatrists, leading many of the staff to view the exhibit largely as a carceral, quote, ward for the hopeless. The aides, Ben Choder suggested, quote, thought of themselves as custodians, not therapists. But with interactive television, Ben Choder and Whitson could add regular rounds on each ward with psychiatrists back in Omaha, depicted here in this cartoon. Today, she concluded, quote, success of the project can be seen in the unlocked doors, the changed staff attitudes, the patient participation in hospital therapy and work programs, and the appearance of the ward itself with its freshly painted furniture and new curtains. As the total inpatient population of the hospital dropped during this time period, for reasons many of you in this audience will recognize immediately as a complex multifactorial process leading to deinstitutionalization more broadly in American life, Ben Choder and Whitson interpreted the dropping census of the asylum from nearly 1,000 in 1965 to 476 by the end of 1968 as evidence for the grounds of therapeutic success. The declining enrollment in the hospital was because telemedicine was working and the hospital was transforming from a custodial or carceral institution into a therapeutic one. Though Ben Choder also noted some reluctance, more on the part of staff than on patients, in her voicing. All in all, the system had remarkably few technical problems. The accounts I've seen suggest that over the 5-year operation of the system, there were only 24 hours of downtime due to technical issues. By the time the project funding ended in 1970, the system was still being used 45 to 50 hours per week. And as Whitson told a later researcher, quote, it had a great symbolic effect. The Nebraska Psychiatric Institute became more a part of the state system than any similar institution I know of. As one result, Nebraska may well become the first state to do away with state mental hospitals. So I'll end this discussion on this odd note that the success of a telemedical link to an asylum would have been, in Whitson's terms, the closure of the asylum itself and the liberation of those held within its walls into a broader community. I'd now like to turn to Ken Bird and the work of the Logan field station. But first, I'll give you a break. You've been listening to me already for a little bit. Here's a murmuration of starlings. I personally find these absolutely fascinating to watch. I have no idea how they communicate their flight so precisely. It is quite soothing to the eye, and I would think also to the mind. But these murmurations can also be sinister. One murmuration in particular is deemed responsible for the worst aviation accident ever to affect the Boston Logan Airport. And this was an event that took place when the starlings in question, moving en masse, flew into the engine of an Electra turboprop plane taking off from Boston on the morning of October 4th, 1960, resulting in the sudden stalling of the motors and its collapse and crash in the shallow waters of the Winthrop Bay. Although many of the passengers were dead on impact, including both pilots, a large number of fatalities are thought to have initially survived the crash, but then died due to the lack of prompt medical attention. As radio broadcasts carried the news of the crash, hundreds of spectators and would-be volunteers took to the roads to see the spectacle, but this had the after effect of blocking highways for emergency vehicles on key roadways. Boston's Massachusetts General Hospital, which you can see just over on, just to the left of, just north of where the Boston City name is, over in the West End, is only 2.7 miles away from the Logan Airport, and yet it was too far away for there to be an effective emergency response. In response, as processing this disaster, the director for the Massachusetts Port Authority, John O'Halloran, reached out to the head of Massachusetts General Hospital, Dr. John Knowles, to build a, quote, miniature hospital in Logan to respond to future air emergencies. And its first head of this clinic was a young internist and pulmonologist named Kenneth Bird. Bird was interested chiefly in pulmonary and cardiovascular care, but along these lines became motivated in this new position that he was responsible for to think about the broader problems of doctor shortages, limited accessibility to care, and ways for new media to impact medicine. He was very interested in Marshall McLuhan's writings, for example, on the role of media as extensions of man, and wondered how new media could be extensions of physicians in particular. And he was encouraged in this process by his boss, by the head of MGH, John Knowles. When the station opened its 24-hour service at Gate 23, 3 years later, Bird initially focused his research interests on disaster management and the impact of airplane noise and jet fumes on hearing and lung function of those who worked in the airport. Bird and his colleague, Dr. Joseph Miller, staffed the clinic between peak commuting hours, 8 to 10 a.m. and 4 to 6 p.m., and were then on telephone call by pager, which newspaper reporters called a, quote, bellboy signal device snapped to their belts. But the real full-time staffers were 24-hour nurses who staffed the clinic the rest of the time. Yet the limitations of medicine by telephone soon became apparent to all involved in the clinic. Quote, one of our patients, Bird would later recall, quote, was an elderly woman who had injured her hip. The medical station nurse telephoned me a full report of the woman's symptoms, but I just couldn't be sure of the diagnosis. Despite all our efforts, I had to face the fact that a verbal report just wasn't enough in a situation like this. If only I could see the patient, I thought. There was no choice but to bring the woman by ambulance to the hospital to determine how extensively she was hurt. But of course, I could see the patient at a distance, he continued. If I could see a space launch 1,000 miles away in Florida and hear an astronaut's heartbeat 1,000 miles up in space, there was no reason why a patient a few miles away couldn't be seen and his vital signs checked while the nurse led him through a physical examination. Much as Whitson and Ben Schroeder envisioned stretching diagnosis from oral to audio-visual in the psychiatric frame, Bird sought to stretch the diagnostic capacity of telephone by adding television to the frame of trauma management. MGH was 2.7 miles away from Logan. The task, however, of getting a TV signal between the two places proved more challenging than Bird had immediately conceived. Privacy concerns had to be met. The FCC had to be mollified. The signal wouldn't be picked up by casual TV sets or interfere with other bandwidth, and needed to figure out how to build the technology. Working with an engineer from WGBH, Richard Oldham, Bird eventually was able to get a line-of-sight microwave transmission pathway set up between the two sites, illustrated in this slide. After winning a 3-year grant from the U.S. Public Health Services, Bird and Oldham set about building a telediagnostic clinic of the future. Closed-circuit TVs were equipped with a range of cameras for long shots and close-ups to aid physical examination. These cameras would be guided by the nurse. Some cameras could be remote-controlled by the physician in the private studio off the emergency room in the Massachusetts General Hospital. Other cameras could transmit X-rays, electrocardiograms, and video microscopy of blood smears. Here you see on the right a nurse mobilizing the video camera on the microscope to send an image of a blood smear to a doctor back at Massachusetts General Hospital. All of this information fed into the console of the physician back at the main hospital, which ran as a parallel studio with its own camera and microphone as well. The clinic opened in April of 1968 to great fanfare. As another Globe article reported, quote, the doctors are never more than a few feet away from their patients, even though the latter are at the airport and the doctors are at the hospital downtown. A third-year medical student at Harvard Medical School, rotating through the clinic, described it in turn as a clinic in which, quote, the doctor's stethoscope is 3 miles long. Now, this medical student was a more gifted writer than most, perhaps. We are all, I know, in this room interested in training medical students in the medical humanities. But Michael Crichton, who had just a year earlier published his first science fiction novel, The Andromeda Strain, to great critical acclaim and eventual a well-known movie and a remarkable career in science fiction, it still is noteworthy that his second book, 5 Patients, spends 2 sections depicting the work of the telemedical clinic at Logan Station, finding science fiction in the contemporary practice of Logan's Gate 23. Bird also liked to describe his clinic as a form of science fiction in the present. Where Whitson and Ben Schroeder depicted their telemedical experiment in Nebraska as an effort to bring modern metropolitan psychiatry out to the rustic hinterlands of rural areas, Bird saw his jet-setting patient population as denizens of the future. Quote, "We have always viewed the 5,000 employee population of the airport as a prototype of one community of the future," he told the Boston Globe. Quote, "Heavily dependent on radio communication, aware of the value of electronic aircraft aids, including radar, and accustomed to the daily use of the closed-circuit television as currently used for flight schedule information. This community already is convinced of the value of applied electronics and thus has set its own stage for the acceptance of medical electronics." On the basis of the Logan experience, Bird then coined a new term, telemedicine, to mean, quote, "the practice of medicine without the usual physician-patient physical confrontation, or the practice of medicine via interactive television." The television was a key technology to telemedicine. He is, to my knowledge, the first physician to quote Marshall McLuhan in a grant application, quipping in a 1970 proposal in which he coined the term telemedicine that, quote, "Time has ceased, space has vanished, we now live in a simultaneous happening. Ours is a brand new world of all onceness." So this is 1970 grant application. Bird was also fond of quoting McLuhan on how broadcast television as a cool media, quote, "permits an intense commitment and has become, quote, the most recent and spectacular electrical extension of our central nervous system. But it could be even cooler." Bird chided McLuhan for ignoring what he called, quote, "the unidirectional limitation of present-day television." Bidirectional television, in contrast, quote, "permits a dynamic interaction which allows interpersonal communication across distance to recreate and even enhance face-to-face communication. When an interactive television system is augmented with medical, diagnostic, and monitoring instrumentation, a telemedicine circuit emerges." But as with the Nebraska project, the electronic mediation of visual materials in Boston came with perils as well as promise. Even though color television was available, for example, Bird and the engineer Stanley Cranen at CBS, who helped him on several projects, preferred black and white. Bird was concerned, quote, "that a poor color picture could lead to erroneous patient assessment and diagnosis. And so standard graded color cards could be used when necessary, and comparisons were made and verbally transmitted." So a decision was made here that color was not necessary to having fidelity of image, and wherever color was necessary, the trained eye of the nurse could be trusted to judge the color and relate it verbally to the physician on the other end. So this decision of what kind of information can be carried by image and what kind of information can be carried by text is not nearly as clear-cut as we might think, very socially negotiated. Now, the images here, much like the ones I began this lecture with, are from a series of tests of the visual capacities and limitations of different lenses and different video enhancement algorithms on the ability to distinguish key features on microscopic, radiological, or physical examinations. And again, this odd, heavily mediated interface of photographs of television screens displaying the results of different cameras of the underlying material to be transmitted. The focus is all on mediation, what is gained and what is lost in different means of mediating information across a distance. And I would argue this forms a kind of science of similarity that tested the signal-to-noise ratio of television as a diagnostic medium. Beyond these technical dimensions, the telediagnostic clinic encountered a degree of skepticism as well by patients and practitioners. In Bird's papers at MGH is preserved a piece of doggerel, seen here on the right, on Logan Medical Station letterhead, presumably set to the tune of "I Can't Get No Satisfaction" by the Rolling Stones, which had reached the charts a few years earlier. And I'll read a little bit of it to you. It's, "I don't want no telemedicine. I don't want no doctor's smile." I'm not going to sing. "Flashing on a television over any span of miles. I don't want no diagnosis with a 1500 lens. I don't want no eye exam with a camera focused in. I don't want no doctor peering down my throat from miles away. I don't want nobody listening to my heart on microwave. I don't want no shrink or rappin' diagnosing my mind's ills. I don't want no one prescribing any television pills." And then underneath, in a slightly different rhyme scheme, sentiments like these are heard from many doubtful patients who like to shake a doctor's hand and feel depersonalization. That's a stretched rhyme, a stretched couplet. Anxiety is soon allayed when dire need takes over. Technology and medicine provide the needed doctor. Technology and medicine provide the needed doctor. So this line can resonate in many different ways with an audience. It has echoes of Big Brother, as does the image on the left with the giant eye on the screen, or it can be an expression of the liberatory capacity of new technology to bring care to those who otherwise are not able to access it. These echoes of Big Brother notwithstanding, Bird's telemedical field station was widely considered a success and found its way into many prominent popular periodicals in the late 60s and early 1970s. It was considered a success in the memories of its nurse practitioners and medical staff, in the accounts of many patients who received care there, and as an engine for producing publication after publication about the value of medicine by television, which helped further Bird's career as a telemedical visionary, and also the broader development of this imagination of what one could do with multimedia instantaneous communication to building meaningful medical networks. Now, these two episodes I've offered you, one rural, one urban, one psychiatric, one somatic, did not go unnoticed by many, many others within public health and health policy at the time. On the one hand, both Ben Schroeder and Bird went on to successful careers developing biomedical communications. Both of them were awarded subsequent grants to develop further pilot structures. For example, both of them built broader networks of telemedical systems within VA hospitals, Ben Schroeder in the Midwest and Bird in New England. But also more broadly, these two episodes were stitched together by other parties interested in advancing capabilities of telemedicine. When in 1971, Bird's boss, John Knowles, left the Massachusetts General Hospital to become the head of the Rockefeller Foundation, he took his vision of television medicine as a community medicine of the future in McLuhan's Global Village with him, and commissioned a report on the future of telemedicine titled An Introduction to Telemedicine, Interactive Television for Delivery of Health Services. And you see in his introduction here, Knowles argues, as head of the Rockefeller Foundation, that the major issues besetting the American people in the field of health are those of cost, quality, and accessibility of services. I have long been convinced that two-way television between urban medical centers and those in suburban or remote rural areas could do much to contain cost while enhancing the quality and accessibility of needed health services. So this is not technology for technology's sake in the eyes of Knowles, Ben Schroeder, and Bird. It is technology which offers the capacity to liberate from an overly cumbersome health system that is itself perpetuating disparities by centering resources in a few institutions in urban settings. And the contents of the report are fascinating. I can't go into them in detail here, but like Ben Schroeder and Bird, this Rockefeller report moved quickly from the technical limitations of telemedicine, black and white, color, image resolution, downtimes, to the more challenging psychological dimensions of learning to accept a physician or a patient mediated through an electrical screen. Here you see one set of discussions that come up in the Rockefeller report about the problems of eye contact when there's an apparent parallax between the screen and the camera so that eyes are never actually meeting each other, and suggest a device being developed by teleprompters for the nightly news, and also developed more formally by Earl Morris in his capacity as a documentary filmmaker, of ensuring that actually that this parallax is resolved through technical means. The analysis, though, is optimistic. The Rockefeller report situated the Nebraska and Boston television clinics as the first two steps in a new era of telemedical primary care, poised at the introduction of a new era of cable television to provide a technological solution to healthcare disparities by enabling the widespread practice of medicine at a distance. By 1974, this report could point to 11 new active demonstration projects currently underway, strongly supported by the National Library of Medicine. And here I will just give a nod to the later efforts of Donald Lindbergh, who I am told is watching this presentation at a distance as well in his capacity as head of the National Library of Medicine to continue to support telemedical projects vigorously. But many other projects were supported already by the 70s from the United States Public Health Service, Health Education and Welfare, the National Science Foundation, a fascinating project supported chiefly by NASA, testing television medicine from the inner city in Harlem and the south side of Chicago to the wilds of northern Alaska, from the Miami-Dade County Correctional Center to the island territory of Puerto Rico. And even though all of these programs proved to be technical successes, by the early 1980s, all of these federally funded experiments in achieving healthcare equity through interactive television had largely wrapped up shop, dried up their funding, and stopped operating. There's a significant gap then, which is harder to understand, between the explosive interest in analog telemedical technologies in the 1960s and 1970s, and then the expansion of digitally mediated medicine in the early 21st century. Yet this gap is also bridged. As historians, we emphasize, continuously we emphasize, how to tack backwards and forwards between continuity and change. And I would suggest that this gap is bridged by the similar enthusiasm and fears that actors imagining a new electronic medicine projected into their futures back in the 1960s, which we might now excavate as a form of paleo future of the present. The sort of optimism that suffused the 1966 New York Academy of Sciences Conference on Media and Medicine, in which Ben Schroeder's talk on medical television in Nebraska was followed by a pair of medical futurologists. One hospital director noted that the communication of, quote, sensible information by television would undo the problems of dehumanization and cost increases that had increasingly become mobilized as critiques of the hospital in American society. With medical television, he concluded, quote, tomorrow the hospital will be unnecessary. In the world of tomorrow, another director of medical television predicted at this conference, we will be able to communicate by television as readily as we now communicate by telephone. By 1990, he predicted, everyone would carry a picture gun in their pocket, which would, quote, allow him to readily record images and sounds anytime, anywhere. This masterpiece of miniaturization will be electronic and will carry its own power supply. It will record both still and motion pictures in color and will be totally self-adjusting for both exposure and focus. Records may possibly be made on small, thin discs of durable material resembling poker chips. This basic tool will also be made in a model which will allow transmission to a specific remote location. And many of you have an equivalent of this picture gun in your pocket today. Maybe you deploy it when you go into archives in frenzied bursts. I can see that others of you in this room have in front of you some equivalent of the personal viewer of the future he foresaw, even if yours might not be occupied by such large pictures of teeth. This speaker in particular was also, in addition to being the director of medical television, a professor of operative dentistry. But still, it should remind us that our current enthusiasm for the power of digital media in transforming the informational and health landscapes of the 21st century, in our approach to diagnosis and therapeutics today, and in our approaches to scholarship, data collection, analytic methods, and new media for disseminating our findings, all of these have strong historical precedents, which are easily elided when we focus on the promises of the new. The function of a keynote lecture, as I see it, is to help begin a series of conversations, not to end them. And I've shown you a good deal of images and made you listen to a good deal of text, which I think is relevant to the history of medicine. So at least we can check those boxes off. But as we continue this conference, as we open up today's workshop on image, text, and new digital media in the medical humanities, and as we get into the real meat of this event, which is your own work, I would ask you to consider the parallels between challenges and opportunities that new media bring to the medical historian or the digital humanist, and the challenges and opportunities that new media bring to the clinician, researcher, and patient. They're not that different, after all. What kinds of fidelity do we as historians worry about losing as we lose touch with the physicality of the text itself? What new sciences of similarity are we currently inventing to ensure that all relevant information is preserved in the digital record? And what new dreams for instant collaboration, for unlimited data recall, for universal access do we share? What fears do we have of jobs being eliminated, of important resources drying up as an after effect of these digital transformations? Revisiting the history of the analog patient, I suggest, helps remind us that these new digital fascinations, too, for historians and physicians alike, all have parallels in similar encounters with analog media half a century earlier. Revisiting these older engagements of text and image in the history of medicine, I suggest, can open up a wealth of new research for all of our domains. Thank you very much for your attention today. And so if there's any questions, I'm happy to take them or stand here. Whatever happens, I'm not going to sing that song.
I'm assuming is this on?
Yes.
I don't really have a question. I'm Jean Whalen. I'm from the Bates Nursing History Center. I'm an historian of nursing, and I'm also a nurse, so that's a disclaimer. Because this wonderful presentation I'm watching, and I'm fascinated with the technology of it and the analog versus digital. But the thing that's speaking out to me are those pictures of the nurses and the use of the nurses. And, of course, this is a period of time when they're using nurses in expanded roles. And it's really the beginning of the nurse practitioner movement, although you don't mention, well, you did mention it, but they're not identified as that. And I'm just wondering what your thoughts are about this. It would seem to me that that nurse would be a very critical person in making this a success. And in moving it along as they are today with all types of electronic things that we use in the hospital, and what your thoughts might be on that. And just one other question. Is Bird the creator of the Bird ventilator? Is it the same Bird?
I don't think so. I mean, that Bird is a fascinating character as well, but yeah. I think that's Bird with a Y. But he put it together, and he was a classic tinkerer. You know, put it together out of shortcake tins in his garage, and but yes, it's a different Bird.
Yeah. Okay.
But thank you for that question. It's a fantastic question. It's very important, and I only briefly glanced at the role of the nurse practitioner. And as you know, this relationship of nursing to technology is such an important domain. I'm very indebted to the work of Margaret Sandalowski in opening up this field of nursing and medical technology as a way of getting into histories of mundane medical technologies, the thermometer, and ways in which the nurse herself, and then later himself, become oftentimes viewed as a technology as well. So that being said, Bird at Logan is very much tied up with the fate of nurse practitioners in general. And he recognizes, on the one hand, this clinic only works with nurse practitioners. On the other hand, that the role of a nurse practitioner is emerging at that time. And this is a place in which, for the nurse practitioners themselves, and I'm hoping to do some oral histories as the project goes on, for the nurse practitioners themselves, this is a space to expand on and demonstrate the autonomous and increasingly autonomous sphere of nurse practice. And at the same time, it's tied into the technology which potentiates it, right? So on the one hand, first it's the beeper and the telephone, and then it's the camera that allows the nurse to act autonomously, or exactly the opposite, that allows the nurse to actually be under constant surveillance and not act autonomously at all. So it's a conflicted history that emerges. Similarly, in another telemedical demonstration that takes place in Arizona called StarPack, which is funded by NASA and stands for Space Technology Applied to Rural Papago Advanced Health Care. Arizona is chosen partly because it is the only state in the country that has physician's assistant laws that at that time that allow physician's assistant to practice independently in a way that potentiates telemedicine. But it's also a way of saying that just as Bird quotes McLuhan to talk about the extending media as an extension of man, and therefore media as an extension of the largely male physician, these nurses also fit as an extension. And we still see that language today, the idea of the extender. It's I think, a really problematic term, but as we try and envision broader utilization of primary health care systems, the idea of people who are considered physician extenders, and the ways in which nurse practitioners at the time both identified with that and chafed and challenged against that. But thank you for the question.
Thank you.
Yes.
Thank you very much. That was a really interesting talk. And when you look back to what was technically possible, and as you say, in the 80s, they all kind of disappeared, it reminds me of the real interplay between technology and policy, and technology allowing people to see that maybe certain changes in policy are desirable, and then sometimes the refusal to change the policy limiting the technology or vice versa, and it goes in cycles, because really the reason why we didn't have more telemedicine in the 80s was you wouldn't be paid for it, and you had these real problems of interstate licensure of, and I see my colleague over here, Michael Ackerman, who reported to me not long ago that he'd just been to the latest meeting of the American Telemedicine Association, and those two major problems, which have been discussed for 40 years, are still right there. But that leads me to believe that in the area of the availability of images and text for the kinds of digital projects that we're dealing with here, technology and policy have really worked very well together. So the fact that you can make many more things available to more people because the technology enables it has actually driven policies, in the case of things like the NIH public access policy and other public access policies, to take advantage of that and drive ever more stuff to be more available to people. So that's a much cheerier story than the one around telemedicine.
I agree, and I want to amplify a couple of things you just said. One is the relationship between science and policy so saturates the story in a way that the actors themselves are entirely aware of. Part of what I'm trying to do is recapture this moment. Really, you could see it as a great society project, really, in many ways in its inception, and the kind of enthusiasm and the sorts of virtuous cycles that were anticipated to develop. And there are many points in that chronology we can understand what happens that brings these things really to a crash in the 1980s, although some of their limitations, as you point out, were already evident in the late 1970s. But at the same time, as I've been going through these fascinating conferences, could I get the visuals back for a second? Well, you can imagine a visual if not. But as I've been going back through these conferences in the 70s, that you see simultaneous conversations about telemedical potential and bioinformatics and biocommunications. So at the same time, at these same conferences, there's presentations by Marty Cummings on MEDLARs and on Medline and on how mesh headings are taking shape. So in a way, these two dual projects can be seen, both of them supported by the NLM, one of which is able to perpetuate that virtuous cycle, the other of which, in a way, trying to actually deal with the world of medical informatics perhaps involves fewer variables than the broader project of instituting a practice of remote medical care. But thanks for that question. Oh, sorry. Which microphone? Michael, I think you're up.
Okay. That was a fantastic talk and a great show that you put on. And of course, what I'm thinking here is about this is a really how to get modern story, and of course, modernity being a moving target. And there were a lot of striking things that you showed in your show, but one was about their show, and struck by the number of cartoons, and sort of thinking about in this hyper-mediated world of the 1960s where everyone wants to do the most modern thing. It seems like the most modern thing in that moment is that you have to show everything, as we show today, but almost a necessity to have a staff cartoonist at every juncture and node. And you showed one slide where there's kind of a list of all the things, partly an echo of mass mobilization campaigns where you have the exhibition, you have the motion picture maker, you have the animator, you have the cartoonist, you have all these different, and of course the television hookups of various kinds. And it's sort of a total system of which it seems like the cartoonist has an important role to play. I just wonder if you could comment on that.
Sure. It's something I'm fascinated by. I don't have a good answer, which is to say, every time I look at, say, Ben Schroeder's cartoons, I find myself wondering how she wrote that into the grant, and how I can get a cartoonist of my own. But I think one partial answer to this is actually Ben Schroeder herself is part of a growing movement of people interested in visual medicine. So that there is a visual medicine movement at the time that converges on audiovisual studies. new journals are founded, for example, the Journal of Biomedical Communication, in which the limitations of television, the photograph, and media, as opposed to the potentialities of iconic or idealistic images, are things that medical illustrators themselves are already well aware of. You know, the decisions made by Frank Netter, for example, in choosing why a more cartoonish anatomy of the body might be effectively more modern than a photographic one. So I think that this is there are broad connections that help it make sense to someone like Ben Schroeder to have a cartoonist available, where other people applying for grants at the time would not have thought to write that in. But that's just that's a short answer to say I'm also fascinated by that question. Yes.
Hello. I want to comment and one question. The comment is that Logan could work because it had the incredible resources of Mass General Hospital. You know, so I'm just wondering how that would play out in other parts of the country where you didn't have the resources of such a fabulous hospital. And the second question is, are there certain fields of medicine that are more amenable to telemedicine?
Okay. So I'll take the second one first, which is to say, yes. And I think that if you go to the American Telemedical Association, their website, you'll see a whole sub-listing of telemedical specialities, or telespecialties. And, fields like psychiatry are seen early on. Pathology, where the slide, a faithful reproduction of a slide of human tissue, well stained, well preserved, is thought to be relatively unproblematic. Teledermatology is a different story. You might think that dermatology would be an easy early adopter of telemedicine because it's such a visual specialty. But then as a result, there are all the more concerns about how to faithfully reproduce. So I think part of the history of telemedicine is a heterogeneous history, which then leads to questions about health equity, right? As we fund more telemedical programs and see more of the public health strategy of our country being medicine as a distance, there are certain kinds of patients that will be advantaged, other kinds of patients that will be disadvantaged in such a scheme. There are certain kinds of physicians who will be advantaged and others who will be disadvantaged in such a scheme as well. The first question, I must have been, I've already forgotten.
The question, it really wasn't so much a question, it was more of a comment. Mass General Hospital has
Yes.
So of course Logan could
Yes. So I was going to respond with a question to the audience, which is to say that in both these cases, in both MGH and the Nebraska Psychiatric Institute, you have a facility with resources which potentiates the spread. Whether it's over 2.7 miles or 113 miles, the principle is somewhat the same. So as you see this next raft of telemedical demonstration projects in the 1970s, all of them imagine one form of disparity across which people are not getting the health care they deserve, and yet all need to go to a granting partner that has the resources to distribute. So I wonder, can you imagine, as an audience, what would you guess would be some of the populations that were imagined to be in need or who had a health disparity that could be resolved by a communications technology? Just shout it out.
Rural medicine.
Sorry?
Rural medicine.
Rural medicine, so certainly.
Alabama had a large telemedicine.
Yeah, so there are a series of demonstration projects about rural medicine. One very notable early one with the grant goes to Dartmouth, but the target population are largely a rural white population in northern Vermont and northern New Hampshire. Other populations. Who else?
Tribal populations.
So tribal populations, yeah. So Native Americans, there's two projects. There's a StarPac project on what's then called the Papago Indian Reservation along the Mexican border with Arizona, and that's the one funded by NASA. There's another project to Alaska, Alaskan natives, and the grant goes to Stanford using satellites to do televisual medicine. And I'm not going to make you go through the rest of them, but I mentioned already how picture phones, the grant went to the University of Chicago to find a way to overcome the disparity between the University of Chicago and the south side of Chicago. Similarly, a grant goes to Mount Sinai to target populations in Harlem. And these are very different imaginaries of how social disparities take shape, and yet there is, I think, a very sincere commitment on using technology to alleviate them. So that's a longish answer just to say that the idea of a center with resources to be mobilized is key to telemedical imaginaries, but the distance at which they can be mobilized is the thing that actually changes. Who's next? Yeah.
Hi, I'm Leanne Craig, and just as an aside, I know how murmuration works, if anybody wants to know. That said, catch me in meat space.
I want to see the microphone to you now.
Yeah, I'll later. But I'm curious about the question in all of this of patient reception, and you brought it up with the clip of the Stones song, but you have here in this talk two very different populations, both of which are arguably captive. In one case, literally, and in the other, there's no other medical help available to them where they are at the airport. Do you think that questions of patient reception may have fueled this slowdown in the 80s of the adoption of telemedicine, or do you think it was more a question of the structural issues from the medical side?
It's a really good question, and right now I don't have the data to get at it, although, as I mentioned, this is an ongoing project, and these are questions I would like to get at. As you can tell, the voices of patients where they do come through here, which is in a very limited fashion, are all mediated. It's all ventriloquism, right? It's all mediated through those who were the principals behind these projects. And to some extent, media. So Boston Globe spoke with patients. Michael Crichton interviewed patients, but the patients presented pretty much only had positive things to say.
Right, and if you're speaking with the population from Logan in the mid-century, you're also talking about a fairly affluent, fairly wide population. So it's a very limited subset of the American public.
Yeah, and so this question of whether utilization dropped, although there are bits of anecdotal evidence to suggest that many people in very different populations responded very positively. So for me, it's a great question, and it's an open area, and it's one that really needs further investigation. But thank you. Yes.
Hello. Thank you very much for the talk. My question is about the relationship between technology and medical authority. And I was very struck by this issue of declining patients, and that the success of telemedicine would mean the closure of some of these institutions, because one of the ways that physicians in particular established medical authority was with their association with institutions. And so I was wondering, and obviously now we live in an age of WebMD and Dr. Google, so I was wondering if there were critics in the medical community that were worried about either standards of care in telemedicine or accuracy or even potentially extinction of the profession.
Yeah. So yes, very much so, and that forms a fascinating counter voice to this. I could say a couple things to that. One is that in the 1970 report commissioned by the Rockefeller Foundation, it's a fascinating document. The author of it, Ben Park, who is in media studies at NYU, among other things, consults with Irving Goffman and with Elliot Friedson. And Friedson, the foremost sociology of the medical profession at this moment in time, or of theories of professionalization and professional boundaries. And Friedson raises a number of critiques that he sees doctors bringing up in terms of how to defend the challenges of telemedicine to this centralizability of knowledge and authority. And I think that challenge is real. But what I would want to point out is that a number of actors in this story, who themselves are physicians, have that as their key rallying cry. These are a cohort of physicians who are sensitive to Thomas McCune's critique of the overreaching claims of biomedicine. They're reading Illich. They're interested in trying to come up with some answer to the criticism of the sort of dehumanizing, centralizing, faceless Faustian bargain that technological medicine has produced. And they paradoxically turn to technology as a solution. And so this is a story that I think is very important to bring out, that we have these single centralizing histories of technology as authoritarian, and yet technology is polysemic. And so what is so interesting to me about actors like Ben Schroeder and Whitson and Bird is that they see themselves as unlocking a liberatory, decentralizing potential that new technology brings. And so when Whitson talks about the success of the project being measured in the potential dissolution of the very institution he's working with, I don't think he's being coy. I think that he is trying to bring into vision a new decentralized vision of community health. And what's interesting is that it does work and it doesn't work. This is the period of time in which the concept of primary care emerges. And the concept of primary care itself is somewhat hierarchical but also decentralized, and relies on a cybernetic or systems analysis voice which all of these actors are sharing. So I think there's a paradox in there that if we take our old narratives about authoritarian technology, we miss something else happening with technology here that's really quite curious. But thank you for that question. Yes.
I think my question may build on that nicely. So I wanted to get back to the question of equity, but I've also been thinking, listening to your talk about more stigmatized medical professions or stigmatized patient populations. And I'm wondering if you can talk a little bit about the ways that this technology has been or could be harvested, used for a more politically radical approach to medicine. So I'm thinking, I'm a 19th century historian by training, but in my other life, I do some abortion access and anti-stigma work. And so thinking about the ways that abortion providers who are a highly targeted medical profession can work through telemedicine and provide abortions in counties that might be hostile to them as individuals, but as well as thinking about populations in prison, that kind of thing. If you can talk a little bit about potentially radical politics here.
Sure. I think that the actors I'm describing right now, I would place more in the liberal camp than the radical camp, but the radical potential of these new technologies was picked up here and there, right? And again, I think there are many more traces to be followed more robustly. I found little bits of it. Carmine Grimaldi, who's a PhD student at the University of Chicago working on video, has been following a group of radical psychiatrists who find ways to deploy video in ways specifically to counter stigma and to try and really push up against broader societal constructions of mental illness. Certainly abortion providers, and this is a very active issue right now, as I'm sure you're aware. And even just recently, NPR carried a very complicated segment on telemedicine and fetal diagnosis and Zika just this last weekend. So I'd like to highlight, as you suggest, that the politics of the technology are not contained within the technology itself, right? Technologies do have politics, but there's a plasticity. And I think as historians, one of the things we can do, this is something that the media historian Jonathan Stern did with sound technologies, is something he calls plastic orality, that, that gramophone records were not originally thought of by their producers as a form of entertainment, and the initial clients were envisioned as businesses. Similarly, telephones were seen to be a serious technology, and Stern mobilizes all of these actors from telephone companies, these campaigns to chide housewives to not tie up the phone lines so much talking because it's a serious technology. And his point is that the media and the technology, the telephone is a technology, television is a technology, have a period of great plasticity before they consolidate as media. And I would just like to amplify that there are multiple histories with radical potential of these technologies that I have not been able to find yet, but I would encourage many of you in this room to continue chasing down. Okay. Thank you for your questions today. You've been a wonderful audience, and I really look forward to the rest of your workshop and your own research in action today. Thanks again.